Hey, everybody. Welcome to this episode of the GAP MASLD MASH Community Network. It's being sponsored by Madrigal Pharmaceuticals. So thank you both to GAP and to Madrigal for having me speak today and for sponsoring this educational opportunity. My name is Ann Moore. I'm a nurse practitioner with Arizona Liver Health in Phoenix, Arizona. You can use this QR code to register for the meeting, so I'll leave it up for just a minute if you want to take a picture. And now we'll jump right into today's topic, which is MASLD pharmacotherapy. An interesting topic, and more interesting seems like every day. So we're going to start off with currently available treatments for dysmetabolic management. Okay, so if you look at the pie chart or the peace sign, the top of the pie chart is really systemic targets. Systemic targets are the foundation of what we do in MASLD and MASH, and remain so to a degree, especially when we talk about lifestyle modification. That's still going to be foundational no matter what pharmacotherapy we're using. So weight loss remains a primary target for us in terms of systemic treatment for MASLD and MASH. So we harp on patients daily in the clinic about their diet and their physical activity. And we know a weight loss of 7 to 10% can resolve MASH in about 80% of patients. However, it's difficult for them to sustain. And, the Mediterranean diet is the diet that has the most data to support its use in the treatment of MASLD for successful weight loss. However, when I see patients in my clinic, it's really important, I think, to be culturally sensitive when you talk to them about diet. And when my clinic is predominantly Hispanic, and if I start talking to them about olive oil, and some of the other components of the Mediterranean diet, they look at me like I've lost my mind, basically. So I think cultural sensitivity is important when you're talking about diet, especially when you're asking for big changes that result in weight loss. So I think talking to the patient, making small changes leads to sometimes big improvements. And the same goes with physical activity. When we're asking somebody to do 150 minutes of exercise a week, sustained exercise, physical activity, it's difficult to imagine for some patients who are so sedentary. Their main activity is their thumb changing the channel with the remote. So I think baby steps there as well will lead to success oftentimes. Then we have prescribable weight loss medications, some more successful than other. I think we can't forget bariatric surgery, which has a lot of data to support its use in our patients with BMI of 35 and above, especially because they have a long way to go. And that 7 to 10% weight loss for them to resolve MASH is likely not going to be, is not going to result in resolution because their target weight is so much lower as the BMI goes higher. So bariatric surgery should still be in the mix, but it's a major lifestyle event for people to have that surgery. They will never eat the same again for most patients, and they need to be psychologically ready as well as physically ready for that. And then, of course, we have GLP-1 receptor agonists and GLP-1 GIP treatment combination therapies as well. And this is where the alphabet soup comes in terms of GLP-1 GIP combos. We have Ozempic, Trulicity, Victoza for diabetes. Those are GLP-1s. We have Wegovy for weight loss, and now since August 15th for MASH, also FDA approved for MASH. And we have Saxenda in the GLP-1 category as well for weight loss. And then in the combination GLP-1 GIP combo category, we have Mounjaro and Zepbound. That's a lot to keep track of, but they offer exciting options for our patients in terms of systemic targeted therapy for our MASLD and MASH patients. And we'll talk more about that in upcoming slides. These targets, really we're targeting cardiometabolic risk. So they can treat type 2 diabetes, but we're also looking at those, minimizing the cardiovascular risk factors, right? So hyperglycemia, hypertension, dyslipidemia. So that's the top of the pie chart. The bottom of the pie chart, which we will discuss in further detail as well, is liver-directed treatment. And that would be vitamin E, except in diabetes, pioglitazone, and the new kid on the block in terms of liver-directed treatment is resmetirom. We'll talk more about that as well. So let's start with the GLP receptor agonist. And not sure if you knew, but we make our own GLP-1. It's endogenous. And after we eat, we naturally make GLP-1. It stimulates glucose-dependent insulin secretion, suppresses glucagon, delays gastric emptying, and it directly acts on the hypothalamus to promote satiety and reduce energy intake. So everything our own GLP-1 does, so do the GLP-1 receptor agonists. So the GLP-1 RAs are just analogs or kind of lookalikes. We're amping up our own GLP-1, endogenous GLP-1. It's a gut-derived incretin hormone, just glucagon-like peptide 1, just like the one we make on our own. So GLP-1 RAs lower blood glucose and cause weight loss. So as you know, unless you've been hiding somewhere for the last couple of months, semaglutide at a dose of 2.4 milligrams once a week successfully met both primary histological endpoints at 72 weeks, showing significant MASH resolution without worsening of fibrosis. This data was presented a while back, but FDA approval under the accelerated approval occurred on August 15th of this year, 2025. So data showed MASH resolution without worsening of fibrosis versus placebo, 28.9% of the enrolled patients or subjects achieved that, and significant improvement in liver fibrosis without worsening of MASH at 14.4% versus placebo. So this is good news for systemic targeted therapy for MASLD. And who should we consider GLP-1 RAs for as we're looking at our patients in the clinic? So for overweight MASLD patients, MASH patients, we should give them a higher priority than those with lean MASH for sure. So if they have MASH with F2 or 3 fibrosis, that's our target as long as they're overweight. So what about how do we deal with the GLP-1s as GI providers? Well, remember that because we're delaying gastric emptying, we can increase the risk of aspiration on anesthesia. So it's important to remember, if you're in a practice that's doing EGDs, that the patient needs to hold their dose of GLP-1 for 7 days prior to their GI procedure, either EGD or colonoscopy, just because of that increased risk with administering anesthesia. And if they've taken it within that 7 days, consider canceling the procedure. All right, so now let's move on to vitamin E. This is kind of old school here. And the PIVENS trial was a landmark study in around 2010 that showed that vitamin E improved liver histology in non-diabetic adults with NAFLD. So an easy way to remember this trial is the PI is for pioglitazone, the VE is for vitamin E, and then you could call it NAFLD study or whatever you wanted to call it for the NS. But that's how I remember PIVENS as a landmark study looking at pioglitazone and vitamin E, just a little tidbit there. It had an effectiveness rate of about 43% of the patients ended up showing histological improvement. But the limitations for vitamin E, not all patients respond, and you can't use it in hypertensive or diabetic patients, has not been studied in that population. There's a little discordance between EASL and ASLD in terms of do they recommend vitamin E or not. And ASLD, their guidance is a bit behind the times. We haven't updated since 2023. And in 2023, that was before we had any MASH pharmacotherapy, right? So They suggested then that vitamin E may improve NASH, we're going back and forth between NASH and MASH, but in the clinical trials to date, it's been NASH because the protocols were written prior to the name change for many of these medications that are in clinical trial now. So it's a gradual transition. It's a transition for me to use the correct terminology. The vitamin E may improve MASH in non-diabetic individuals, but EASL guidelines do not recommend, and these guidances came out in 2024, so we already had a targeted therapy in resmetirom. They did not recommend it as a MASH therapy due to limited efficacy on fibrosis and the potential risk, which include bleeding, prostate cancer concerns. And so if you are going to use vitamin E, or if your patients would like to use it, because some patients do not want prescribed therapy, they like to use over-the-counter medication for whatever reason, you should use cautious consideration and have a patient discussion regarding long-term high-dose use, which would be 800 international units a day. So now what about pioglitazone? Also old school for diabetes use, right? We've used pioglitazone for quite a number of years for the treatment of type 2 diabetes, and the potential use is in MASH patients with type 2 diabetes. So the opposite of vitamin E. Vitamin E you don't want to use in type 2 diabetes. Pioglitazone, you have the opportunity to treat patients with type 2 diabetes. Dosages anywhere from 15 to 45 milligrams a day. Again, the PIVENS trial looked at pioglitazone use and showed that there was no potential benefit of pioglitazone over placebo for the primary outcome, which was improvement in histology, the histological features of MASH. However, there was still significant benefit of pioglitazone when it came to the secondary outcomes of improvement in cardiovascular risk. So it's not fully out of the picture, but it's used less and less. And some of the reasons for that is it has some side effects that which and safety considerations which patients don't appreciate very much. One of them being weight gain and edema. Another being bone fractures, especially in women. So the three of those combined make it a less than optimal option in some provider and patients' minds. So again, cautious consideration. There's also potential for increased risk of bladder cancer. So careful patient selection and monitoring if you choose to use pioglitazone in your patients with MASH. So now we're going to get to the new kid on the block, somewhat new, resmetirom. It seems new, but in actuality, FDA approval occurred on March 14th, 2024, under conditional approval, meaning that there's an ongoing open label extension trial out to 5 years to prove efficacy. But for now, under accelerated approval, resmetirom is to be used in conjunction with diet and exercise. So the FDA did not forget the foundation of treatment for MASH, right? For the treatment of adults with non-cirrhotic, non-alcoholic steatohepatitis, NASH, or MASH, as we now call it, with moderate to advanced liver fibrosis, consistent with stages F2, F3. So this is not for use in cirrhotic patients. It is for use in F2, F3 fibrosis. So at either end of the fibrosis spectrum, either early fibrosis F0 to 1 or later stage fibrosis F4, this is not the drug. The sweet spot is F2 to F3. It is a thyroid hormone receptor beta agonist, forever in the future known as THR beta, because that's a mouthful to say at 4 o'clock in the afternoon. It selectively binds to and activates the THR beta receptor in the liver. So this is liver-directed, liver-targeted therapy for the treatment of MASH. All right. So now we're going to kind of walk through the rationale between THR beta signaling and MASH. And I don't know about you guys, but when I went to school, I had no idea that thyroid hormone targeted anything in the liver. You know, when you think of the thyroid, you think of, I always thought of brain and heart, but really not so much bone sometimes. But I did not have any idea there was any targeting being done in the liver. But it turns out in the healthy liver, THR beta regulates mitochondrial biogenesis and function, fatty acid beta oxidation, and lipid homeostasis, right? So in MASH, impaired THR beta signaling causes this cascade of dysfunction. So there's mitochondrial dysfunction, which results in reduced oxidative metabolism and impaired clearance of intrahepatic fat. So fat is not leaving the liver, it's being stored in the liver. And then there's lipid accumulation, which drives steatosis and lipotoxicity, which promotes hepatocyte stress and death. So that's ballooning of the hepatocytes, which we see in our when we look on histology. And this all in turn leads to increased inflammatory signaling, which activates the Kupffer cells and the stellate cells, which perpetuates hepatocyte injury and leads to fibrosis. And all of those mechanisms combined accelerate fibrosis progression. So that's what we're looking at in terms of what's going on when THR beta signaling is impaired. And so what Rezdiffra or resmetirom does, it's a selective THR beta agonist, and it restores those pathways. So it directly stimulates hepatic THR beta. So right there in the liver, activating, doing its thing. It improves mitochondrial function. It promotes lipid mobilization and oxidation. And this reduces steatosis. And when that happens, pro-inflammatory and pro-fibrotic signaling is downregulated. And so less inflammation, less of the activation of the fibrosis pathway leads to improvement all the way around. And so liver is really, or Rezdiffra is really a liver-directed, mechanistically targeted therapy. It addresses the upstream defect driving MASH and fibrosis, not just the downstream consequences. So it's great to have a targeted therapy. And I think this is why we can say that resmetirom really is complementary and not competitive when you look at systemic targets that are looking at, the cardiometabolic dysfunction. So liver targeted therapy in the form of Rezdiffra, I see as complementary. It really restores a core hepatic pathway. And I'm hoping that we can eventually sort of layer it with the systemic approaches that we have in GLP-1 and future drugs to come to kind of address the full spectrum of MASH biology. So that's it in a nutshell. Hope you enjoyed that little sermon from me. But that's kind of that. I like the pathophysiology of THR beta agonists, and so hopefully you learned a little bit with that. So now we're going to talk about the registration trial for resmetirom. Rezdiffra. It's Maestro NASH, and it is an ongoing, as we talked about earlier, phase 3 randomized control trial. It studied adults with biopsy confirmed NASH and a fibrosis stage of F1B, F2, or F3. So you can see they had to have either from early fibrosis to F3 and no cirrhotics in this registration trial. There's 966 patients who were randomly assigned in a 1:1:1 ratio, 80 milligrams, 100 milligrams, or placebo. And there's two primary endpoints in all the MASH or NASH, however you want to refer to it, trials. And this was at 52 weeks. So I want you to pay close attention to this because these are hard targets to hit in just 52 weeks. If you remember when I was talking about Wegovy, their data was at 72 weeks. So Maestro NASH with resmetirom was read out at week 52, and it achieved both primary endpoints, which are NASH resolution, which includes a reduction in the NAFLD activity score by 2 or more points with no worsening of fibrosis. The NAFLD activity score, or the NAS score as we like to call it, is steatosis, ballooning, and inflammation. You have to have at least 1 point in every one of those categories. And to enter into this trial, you had to have a NAS score of 4. So to achieve NASH resolution, you had to have a reduction by at least 2 points in the NASH score with no worsening of fibrosis. And then on the flip side, you had to have an improvement in fibrosis by at least 1 stage in 52 weeks with no worsening of the NAS score. So those are tough targets to make, and look at resmetirom did it in just 52 weeks. So what about safety that was data from the study? Resmetirom was proved to be quite a safe drug. really the main adverse events that were seen and associated with resmetirom versus placebo were the GI hit parade, most significantly diarrhea and nausea. And the incidence of serious adverse events was similar across all the trial groups, so not many serious events at all in any of the treatment arm or placebo. So if you take a look at diarrhea, 33.4% in the 100 milligram arm, 27% in the 80 milligram arm versus 15.6% in placebo. In nausea, we saw a little bit more nausea in the 80 milligram arm as opposed to 100 milligram versus placebo at 12.5. What I will say about diarrhea and nausea is we do see them, they tend to be seen early on in the first 4 weeks, and they resolve very rapidly. And most patients in the clinical trial described their side effects as mild to moderate, and there was very few discontinuations related to any side effects experienced during the trial. So well-tolerated drug. So what about the primary endpoints? So both resmetirom 80 and 100 milligram were superior to placebo with respect to NASH resolution and improvement in liver fibrosis by at least one stage. So you can see on the left of your screen, NASH resolution with no worsening of fibrosis was seen in the 100 milligram arm in 29.9% of patients, in the 80 milligram arm, 25.9% of patients versus 9.7% in placebo. Then we look at the other endpoint, which was fibrosis improvement by one stage or more with no worsening of the NAFLD activity score. That was seen in 25.9% of the 100 milligram arm, 24.2% of the 80 milligram arm versus 14.2% of the placebo arm. So both clinical endpoints met, and this resulted in FDA approval of resmetirom under the accelerated approval. So what should we be thinking about when we're managing our patients with resmetirom? Well, first is who's ideal for treatment with resmetirom. So any treatment with any adult with non-cirrhotic MASH is a candidate. We need to stage their fibrosis. And the sweet spot, as I said before, for treatment with Rezdiffra is stage F2 to F3 fibrosis. Do you need a biopsy to figure that out? Not like the clinical trial. Thankfully, you do not. You get there with non-invasive testing. So whatever your flavor of choice is with non-invasive testing, it could be with imaging with VCTE or FibroScan, MRE. You could use simple NITS laboratory tests to figure that out, as well as like the enhanced liver fibrosis test or ELF test. Those are the ones that are mostly in the guidances. But whatever the resource you have that's available to you in your clinic to get to that F2, F3 target in terms of where you want to be is for treatment is the NIT you should use. And remember diet and exercise. So lifestyle modifications are still important in this group of patients with at-risk MASH. So other practical considerations include drug-drug interactions. What should we avoid? Well, you need to avoid strong 2C8 and or OAT1B1 or 3 inhibitors, and some of the medications that fall into that category are listed here. I would say most of them are not things that we use frequently, but just be aware and use your DDI, whatever I use the Liverpool DDI website to find out what I can and can't use when I'm prescribing medications, but you do whatever you need to do, but that's a list of medications to avoid. Some of the medications in the middle column here are meds that you can use with resmetirom but require dose reductions, and the most significant there is clopidogrel or Plavix. So if you have a patient on 100 milligrams of resmetirom, you would come down to the 80 milligram dose. If you have someone on 80 milligrams of resmetirom, there is a 60 milligram dose available. So it can be used with Plavix, but with dose reduction of your resmetirom. So don't forget about that. The deferasirox is iron chelator. and can be used as well. But the dosage, I can't tell you. You're going to have to figure that out. I would say a word about trimethoprim. If it's for short-term use, the dose of resmetirom likely does not need to be reduced. But if you have somebody who's on suppression with Bactrim, say, every day, then you would have to likely dose reduce your resmetirom, because there is potential for significant exposure to resmetirom without dose reduction. What about medications at risk of increased exposure due to resmetirom? So those would be pioglitazone, which we talked about before. Use that at a max of 15 milligrams a day. Some of these other medications, not as common. No dose adjustment for montelukast. That was studied in a clinical trial, but just be aware. There are some statin doses that you shouldn't exceed, and that would be for rosuvastatin and pravastatin, 20 milligrams for rosuvastatin, 40 milligrams for pravastatin, 20 milligrams for simvastatin, and 40 milligrams for atorvastatin. So just keep in mind, when you're using steroids, you need to know the max dose that's allowed. Otherwise, you'll have overexposure to your statins and may end up with some myopathies. So just be aware. So what are some other practical considerations for managing MASH with resmetirom? Well, I think we're still learning about these. We're 18 months in. We haven't had new guidance from ASLD to help us out here. We know that expert panels are currently working on cut points and periodicity for testing. So, how often do we test and what are the cutoffs? And I think there is a paper that was published in the Journal of Clinical Gastroenterology and Hepatology in 2024. It was expert panel recommendations for how we're treating and monitoring patients with MASH. So you might want to check that out. But ongoing evaluation of just these things continues with the Maestro-NASH trial that's going out to 5 years. So stay tuned for more data from that study. We absolutely will need to restage fibrosis, and typically we're doing it at 1 year of treatment and steatosis. And we're not going to use liver biopsy, that's for certain. We'll use non-invasive testing, as I was talking about earlier, such as VCTE, PDFF, which is MR proton density fat fraction, CAP score, controlled attenuation parameter from the FibroScan, or ELF, which is the laboratory test enhanced liver fibrosis test, all of which are typically covered with insurance with more and more likelihood, I think. And also Madrigal has a program where they will pay for NITs $500 twice a year. If you don't know about that program and you have a test that was denied by insurance, you should go on their website and check that out, because it's a handy way of getting ELF paid for if it gets denied by chance, or one of the other tests too. If you can't get MRE and you really feel like you need an MRE because a patient has a body habitus that doesn't lend itself to VCTE, there's possibility there for some financial assistance from the Madrigal company. So what about questions that remain? Well, certainly with any new medication, the widespread use depends on insurance coverage, right? I think, we're 18 months in, and I've been pleasantly surprised with the acceptance by insurance companies for use of resmetirom. I think good documentation of the criteria for use, MASH with F2, F3 fibrosis, needs to be in your notes in order to sort of smooth the path towards approval. But again, pleasantly surprised with this. So I think we're moving in the right direction. I think, it's important, resmetirom was the first approved MASH therapy after 80 plus drugs that went to the graveyard because they didn't meet the clinical endpoints. And so this has been a learning curve for us. Now with Wegovy, it will be the start of another learning curve to see how insurance is going to respond to our request for that, for MASH specifically for the indication. So stay tuned. We're still talking about when do we do staging and when do we do lab tests for monitoring? In our clinic, we tend to do lab tests quarterly. I'm a big lab test person, so I personally get a lab test at week 4, knowing that there's a small bump in the AST, ALT at week 4. But with any new drug, I like to know what's going on. So I typically test at week 4 and then quarterly after that, unless there's an issue. And then, of course, you're individualizing therapy. In terms of staging fibrosis, I think, it's motivating to a patient to see changes in their KPA score if you're using FibroScan or whatever method. However, if you do it too early, it may be disappointing. So we're trying to hold that to a year after starting therapy in terms of staging fibrosis. And then we need more information on what the duration of treatment is going to be for these patients, and when do you need to discontinue. I feel like, this is a lifelong problem for our patients. MASH may resolve with treatment, but if we end treatment, it's likely to recur. And I look at this like hypertension or diabetes. When patients hit their targets there, we don't withdraw the therapy. So I'm hoping that insurance starts to look at this, MASH targeted MASH therapy, similar to those, treatments that continue on even though a patient is at target, because that's what we want after all, right? In terms of when to discontinue treatment, I think we need to look at what is response, really define that. So if we know that someone is not responding how we want them to, that maybe there's other options that should be considered. And remember, there is, just a multitude of agents that are currently in clinical trials, and we likely will have even more options than we do now in the near future. So stay tuned to MASH. It's exciting times for us, and job security with the millions of patients out there that are really awaiting, a therapy in addition to the lifestyle modifications that we will continue to talk to them about. So thanks again for joining me. You can visit the GAP MASLD MASH Community Network for additional disease state education and Resdifro webcasts if you're interested. So there's the QR code for that. So feel free to take a picture. And then we'd love your feedback. If you want to say something either nice or nasty about me, that's okay. So scan the QR code to complete a short survey and share your thoughts on today's presentation. I hope you gained at least one piece of new information that you didn't know before. And really your insights will help us continue to improve and offer some more engaging talks in the future. Thanks again for joining, and hope to see you soon at a meeting or virtually. Take care, everyone. If there's any questions, I'd be happy to try to answer them.